today. And I just want to welcome everybody and thank you all for coming. My name's Matt Winter. I'm the Vice President of VetCT North America. And again, I want to thank you guys for coming. I know it's at different times at different parts of the world. Some people are up very early, such as Fritha, who's on the West Coast of the US. And for some of you, it's lunchtime or after lunch. And I'm sure that, and those of you in Australia are hopefully wanting to go to bed here in the near future. So I just want to make a few announcements really quickly. Next month, in the month of May, we're featuring MRI Summit speakers. There are 2 weeks of small animal MRI starting next Wednesday, and that'll be Fraser McConnell, who's going to do some cerebrovascular lesions on May 6th. And then on May 13th, Olga Trevette will do pituitary MRI. And then after that, we will have Rachel Murray, who will do 2 weeks of equine MRI during the last 2 Wednesdays of May. So it's going to be a pretty exciting MRI month in May. Just for way of review, even though I've said this before, some Zoom instructions and etiquette, just mute your microphones. And actually, Fritha is going to end up, she's already muted everyone, but she'll make sure that everyone's muted just because any background noise can interfere. We are recording these and they will be available on our website. We suggest that maybe you use speaker view and you can use the participants and chat buttons to ask questions. Fritha has done an excellent job of moderating these and we'll make sure that she interjects some questions when appropriate. So please feel free to type them in and click raise your hand, the emoji, so we can go ahead and recognize that. Fritha, as mentioned before, is one of our radiologists based in California, and she's from New Zealand. She trained in Florida, and she will be the moderator again today, watching for questions. I also want to thank Heather Chalmers, who has done an amazing job setting all of these up and pulling from our group of amazing radiologists to come make these presentations, which I think are excellent. So without further ado, I'm going to introduce Tobias, who studied veterinary medicine and Scandinavian studies at the Humboldt and Free Universities of Berlin. He was a resident at Glasgow University and then pursued an academic career as an assistant and then associate professor at the University of Pennsylvania and Wisconsin-Madison. He's been a senior lecturer in diagnostic imaging at the Royal Dick School of Veterinary Studies in Edinburgh since 2009, and he holds a radiology diploma of the RCVS, as well as the European and American Colleges of Veterinary Diagnostic Imaging. You've probably read his book or seen his book on the Manual of Feline and Canine Thoracic Imaging and the Textbook of Veterinary Computed Tomography, and he is the author or co-author of more than 100 peer-reviewed original and review articles in diagnostic imaging. So he is very respected in the field, and we are happy to have him continue his discussion on abdominal CT. And without further ado, thank you, Tobias, who is still muted.
2 seconds.
Hello, everybody. Can you guys hear me now? I take that as a yes.
Perfect, Tobias.
Yes, we're getting lots of yeses. Thanks, Tobias. Go ahead.
Good. I'm going to share my screen. Let me just see how I do that. I think I need to first. Yeah, I think what we need to do is, okay. Everybody should see now the PowerPoint slide in full screen, and you should be able to hear me. Can you confirm that that's the case?
Can everyone send a yes if they can see the screen and hear Tobias? Okay, I'm receiving lots of yeses.
Okay, we'll take that as a yes. Cool. And just so that everybody knows, if you write a chat question now, I cannot see that, but Frissa can. So she will moderate. If it sounds like important, she'll interrupt me and ask the question. And if it's good for the end, we'll do it at the end, okay? Meanwhile, I will just crack on here. Okay, so we've done the liver in the last week, and now we're going to do the other parenchymal organs. Actually, not all of them, but a couple of the abdomen. And we'll start with the adrenal glands. I think CT is an excellent imaging modality for adrenals. You can find them consistently. You can distinguish between the cortex and the medulla, particularly if you use a power injector. You can assess their size, their shape, and their density. Density is actually a relevant thing in adrenals, particularly also in human medicine, but we also see this occasionally in animals with benign lesions having a higher fat content. You can assess their vascular supply or potential invasion of vessels from an adrenal neoplasia. And I think the other thing that's kind of cool is that the CT allows you to investigate the entire hormonal cascade, because you could look at the pituitary gland as well as the adrenal glands, for instance. So medullary neoplasia, the most common one that we see is pheochromocytoma, and they are usually malignant, but there's also benign versions available in existence. And they were thought to be rare, but I don't think they really are that rare. They just are commonly incidental, and or at least at the time of diagnosis, and therefore they have been overlooked. And then we got cortical neoplasia, and they kind of, the going goes, I remember maybe from your vet school days, salt, sugar, sex, the deeper you go, the sweeter it gets. So the different corticoids produced mineralocorticoid at the periphery, then the sexual corticoids in the central part of the cortex, and in the middle, the normal corticoids. And other thing that's also important in adrenal glands is that they are a reasonably common site for metastatic neoplasia, which I think we're not always taking that into consideration. But because they are they have a very strong blood supply, lots of mets get stuck there. So it's something you should consider when you see a lesion in the adrenal gland. It doesn't have to be a cortical or medullary neoplasia. Okay, let me see. Other way, sorry. Here we go. So these are some images of adrenal glands in the rabbit, the cat, and the dog. We'll start. One question I have, when I move my mouse, can you see my mouse? Now?
We're getting some yeses. Yep, lots of yeses.
Okay, that's good to know. On the bottom, you have the dog, and you can see the adrenal glands with the yellow and the red arrows, right and the left one. The left one is always easier to see because it's separated by fat from other structures, and you see the phrenico-abdominal vein and arteries surrounding them. They're relatively easy to find. Whereas the right one is adjacent to one of the pillars of the diaphragm. And so this is post-contrast, and you can see on this image on the left lower corner, the yellow arrow, that the adrenal gland is a bit more contrast enhancing than the diaphragm, but pre-contrast this is often the same density. So it's not always as easy to say what's diaphragm and what's adrenal. But the most amazing thing to me is that when you look at the right adrenal gland in ultrasound, which is a bit tricky, but I've never seen it that it's adjacent directly to the diaphragm. So this must have been some sort of positional recumbency related lesion. Why that is, because in CT it's consistently adjacent to the diaphragm, whereas I've never seen that on ultrasound on the right side. So I just thought that's an interesting observation. On the top right, you see a cat. The adrenals, this is pre-contrast, and you can see there are these increased areas of density in it. And these are mineralizations, which I think you can appreciate. They are more cortical, they're more on the periphery, and they are regarded as incidental in cats, and is something we on occasion pick up as an incidental finding in cats on radiographs, but you can definitely see that in CT as well. And I had some discussions with some medics about this, and they're now wondering whether this might not be a completely normal thing on cats at all. So I think it's an interesting topic, but it's just the same adrenal mineralization that you can see on radiographs. You can definitely see that also on CT. And then interesting, on the top left, we have a rabbit, and I have outlined the adrenal glands here. So we do a lot of rabbit CT in Edinburgh, and we do almost in all of them post-contrast via the ear vein. And so these are post-contrast images, and you can see them as less enhancing as the surrounding vessels. Adrenal glands in rabbits are by nature relatively large, and they are more they're not as longitudinally stretched as in dogs and cats. So they are kind of 4 millimeters or something. That's normal. And we have identified a number of rabbits, I would say 2 or 3, with adrenal tumors. So they do get this as well, maybe not as frequently as other animals, but they by nature already have relatively large adrenals, and that's suspected has something to do with the fact that they are prey species and they're more stressed about things in general. They need more corticoids to keep them up, but that's just a theory. Okay, so you can see the adrenals really nicely on CT and different species. And here is an example of using our syringeless power injector. I think the fact that the power injector is syringeless isn't really the point here. It's just more easy to use because you don't have to reload it all the time, so we use it routinely. But look at this is a dog, and I just want you to focus you on the normal left adrenal gland, or possibly slightly atrophied, but not mass, no mass in there, and the different contrast enhancement patterns. So in the arterial phase, which is on the top, you get the periphery of the adrenal gland more contrast enhancing than the medulla. And then when later on in the portal phase, or venous phase, because the adrenal isn't supplied by the portal vein, so venous is more appropriate, you see that the medulla is more contrast enhancing. I think that's super cool that you can see that difference. And also, obviously, we can appreciate the amorphous adrenal mass on the right as well. So, but using power injector gives you a bit more detailed information about the adrenal gland. And it's something I think we should look into to use more, particularly because these medullary neoplasias are not as rare as we thought in the past. And so when you see a mass or nodule in the adrenal gland, then the question whether this is cortical or medullary is maybe more relevant than previously thought. And so we have things that we can separate the medulla and the cortex with the injection technique. That would be a cool thing. Yes, so you can also use CT nicely to demonstrate hypoadrenocorticism. So this is a dog that has steroid-induced hypoadrenocorticism, and you can really see how small these glands are. So, i.e., you can find them even if they're small, and therefore, you know, have a reasonable confident diagnosis of hypoadrenocorticism. So that is a useful thing. Yeah, that's an older image of a large adrenal cortical carcinoma that is invasive. It's a post-mortem image, and you can see the mass is heterogeneously contrast enhancing, non-enhancing parts in it. There's vascular invasion into the phrenico-abdominal vein and the caudal vena cava. Now, in some papers that came out of that, I think they were from Davis, they reported basically as far as vascular invasion goes, and I think that's something we as radiologists need to have in mind, that all of these adrenal masses had phrenico-abdominal vein invasion. So diagnostic test wasn't really about that. It was more whether that invasion included the caudal vena cava. So obviously depends on the particular cohort of patients that they had, but I do not think that we are really highly sensitive and specific in CT diagnosing invasion into the phrenico-abdominal vein or artery. It usually goes into the vein. I'm not quite sure why, but it does. It's just such a small vessel. You can see it here on the top left. You know, it crosses over that, and it's that little structure here. How do you know that this is really an invasion there? So I think we shouldn't really be too confident about phrenico-abdominal vein invasion. We should be able to make a statement about the invasion of the cava. Has anybody questions or comment on that particular issue? Because I'm interested in your opinion on that. I'll wait a second while I have a coffee. Okay.
No, we don't have anything, Tobias.
All right, we'll crack on. Okay.
Oh, we have a comment
oh, yeah,
from
okay. Go ahead.
Mark saying, it's nice to hear you say that because we feel the same way.
Oh, good. Excellent. So here is a dog with a pheochromocytoma. And I need to look which one, because one of them was my own dog. So, but
we do have one more comment, Tobias.
Okay, what was that?
It's from Ashley saying arterial invasion is rarer because the veins are more thin-walled and easier to get through for neoplasm cells.
Thank you so much, and that makes complete sense. And it's true for many other vascular structures as well. So yes, thank you very much. That is a really good logical explanation. Taken on board. So let's talk about pheochromocytomas. So this is one on the left side, and you can see this large amorphous mass. And on the right side, there is the liver. You can see a contrast enhancing mass here, or nodule. So these are liver metastasis. So there's two types of scenarios of in which context you're diagnosing these masses. One is the dog has some weird behavior with abnormal blood pressures and other things that don't quite make sense, and then you diagnose this mass which fits in the context. But more commonly, the other one is there's something else going on with this dog, and maybe you find something, and because cortical neoplasia is assumed to be so much more common, then that's always the first assumption that this is what we see here, but that isn't necessarily the case. Pheochromocytomas are often very invasive locally, unlike cortical adenomas. And also importantly, they can, when you manipulate the adrenal gland, they can release a catastrophic catecholamine release, which the dog can die from this. So, you know, we don't usually aspirate adrenal masses anyway, but this is one reason why you should think twice about whether you should aspirate an adrenal mass as well. And I think there's some more. Hang on. All right. So, oh, that's Ingrid. That was my own dog. So she had a left-sided malignant pheochromocytoma, which we didn't expect. I hope you can see that there is a mass in the spleen here on the lower left side. So she was used for student ultrasound exercises, and we found the mass in the spleen. And then decision was to remove the spleen. And then we also saw there was something with the left adrenal. And of course it's my dog. She got on CT as well. Well, there was a reason for that because she also had multiple myeloma. Whether this has anything to do with this, there wasn't any recurrence of that. And I said to the surgeon, okay, well, while you're in there taking the spleen out, could you just take that adrenal out? He said, why do you want to do that? Well, it must be a non-functional adenoma because she's not Cushing-weight. And what else should it be? And you're in there on the same side anyway. And the surgeon told me, no, I'm not going to do that because I might kill your dog. But we can put them on these beta blockers and then I'd be willing to aspirate it. And that's what we did. And they took the spleen out, came back as hematoma, and the adrenal gland came back as malignant pheochromocytoma, early stage. It hadn't invaded anything yet. So then she got another surgery 3 months ago where that was removed. And just basically, despite being on these beta blockers that supposed to stop or limit this catecholamine release, the blood pressure, it was like a roller coaster. The anesthetists were shaking in their boots about this. They're not trivial to deal with. And, you know, nobody wants a dog to die on the table, particularly with a member of staff and things like this. So she made it through and lived 2 more years, happily ever after. But it's just that they're not that rare, and you should include that in your differential diagnosis. Okay. Here is one of the more classical pheochromocytomas, the ones that are invading. They seem to be more common on the right side, and because everything's closer to the caudal vena cava there, I think that's why the rate of invasion is higher there. So you can see in this one the filling defect in the cava, and obviously the adjacent mass. You can try and determine, is it a tumor thrombus or just a normal thrombus? If it's a tumor thrombus, then it should contrast enhance, so part of the tumor is in the vessel, or is it just a normal thrombus, then it shouldn't contrast enhance. But I think practically this does not make a huge amount of difference if you have to dissect that out. So, okay. Right, here we've got a cat. So here's a cat with a carcinoma that invades the caudal vena cava. You can just see this kind of bulge going into this. Adrenal tumors are more rare in cats, and they are usually more commonly mineralocorticoid or mixed tumors. And I think that's an example of it. So this is an aldosteronoma. And to see it. Yeah, it must be, I assume it must be this contrast enhancing mass on the left side of the caudal vena cava. But I have another one actually, that one. This is much more cool actually. This was a 14-year-old Bengal cat with hypertension and hypokalemia. And she had a myelolipoma. So all of that is the adrenal mass what was taken out. So we know what it was. So this was almost as fatty as the rest of the peritoneal cavity. So it was a myelolipoma, but it was aldosterone producing. So that's quite interesting because okay, we know that cats tend to have these aldosteronomas rather than the Cushing-weight cortical tumor, but you can also see all the body fat here. So it was kind of probably a mixture as well, probably produced some glucocorticoids as well. And the other thing is that based on human medicine, you have this distinction between benign myelolipomas of the adrenal glands and the more aggressive ones. And this is why you can use density to differentiate the two. But here's an example of a highly fatty infiltrative adrenal mass that is still malignant and hormonally active. So I think the landscape in animals regarding to this fat content and the malignancy is potentially slightly different than what's known in humans. So I think that's interesting. And here's an example of a metastatic adrenal neoplasia. So this was a dog with malignant melanoma, and he had mets in both of its adrenals. So I think you can see the left one here that I'm outlining, and then this is the right one. Part of that will be again the diaphragm, but part of it is that mass. And how do you know that that's a met and not some, naturally occurring bilateral adrenal masses? Well, it's based on context and having mets everywhere else, and the fact that two amorphous masses in an adrenal gland independently is maybe less likely, an absence of hypophyseal masses. So, and there are some necropsy papers out, and I think 20% of all dogs with tumors had metastasis to the adrenals there. These are areas that are likely to have metastatic disease. And I don't think we as radiologists think about that regularly. Okay, here we got a rabbit with a right adrenal neoplasia. So I'll just point it out to you in case you're not sure. So you can see the adrenal glands on rabbits. It just takes a little bit getting used to rabbit CT. So we'll do whole body of all rabbits pretty much. But we do find more and more lesions in rabbits, including the adrenal glands. So it's worth it, in my opinion. All right, well, moving on to spleen. If you have some burning questions on the adrenals, you can put them now. I'm going to start with the spleen, and if they come, I can stop with that. So we do lots of trauma CT. I'm sure you're doing that as well. That has been established now as a very practical, quick means of establishing organ trauma, thorax, and now we're doing this for the abdomen as well. And here's a great example of a dog, a mountain rescue dog that fell off a cliff. And he had lots of other trauma as well, but you can see that the spleen is ruptured and there's this fat stranding surrounding it. So there's some sort of mild peritoneal hemorrhage likely to be the case there. So it's something you can appreciate on CT if that is the modality you want to use for it. It doesn't mean that other modalities are useless, but if this is what you're using anyway for numerous other reasons, then that can be diagnostic as well. Here's something that we don't see every day. This is a dog that had thrombosis elsewhere in its vascular system. I don't remember exactly where, but among all these changes, it also had what we believe is a splenic infarct. So this is post-contrast, like venous phase, late. You can see, you look at the vessels there. And you can see that the spleen has a completely normal shape, but there's this territorial lack of contrast uptake. So classical for an infarct. And also, I'm sure you remember that anatomically, the canine and feline spleen has a segmental blood supply. So there's a bit going here, another bit there, another bit there, and so on. So it makes total sense that you have these territories then that don't contrast enhance. Whereas other spleens, for instance, human spleens, do not have a segmental blood supply. So this potentially would look different there. Yes, so as far as diagnosing malignancy or benignity of splenic masses, I don't think we have made too big strides. We're not really better than other imaging modalities. Yes, there have been some progress with contrast ultrasound, and also I think there was an older study with MRI, but I think none of that is really so reliable or so practical to use that we can say, yeah, we nailed that. We can tell what's what. So here's a hematoma and benign hyperplasia. And yeah, I think one is, well, they're both post-contrast, but they don't really look fundamentally different here. Luckily, we have context. You know, if you got metastasis in the lungs and other changes like that, or big lymphadenopathy, you're obviously going to be more tempted to go towards malignancy. And CT allows you to do that because we can easily scan the thorax and abdomen, for instance, to do this. There's also a bit of fusion here on the left. And this is a splenic histiocytic sarcoma. Again, I'm just putting this in here to show that to me they all look the same. And I wouldn't dare make a diagnosis. And I have the evidence. I've done this on my own dog. So I do what I preach. So we took the spleen out. I didn't know what it was. It was benign, fine by me. So, and here we got a hemangiosarcoma in a cat, which was visceral, so it wasn't just in the spleen, but also now we have all these nodular, non-enhancing lesions in the liver as well, which by per se, they could again just be any nodule, benign or malignant, but maybe in context makes it more likely that is metastatic. So bottom line is, I think as far as splenic neoplasia is concerned, is the only way to assess benignity or malignancy with confidence is to context, to look at other abdominal and thoracic structures. That will add up to being more confident one way or the other. And here we have a wonderful, I know last time Andreas was in the talk, so he might see this one, but I've acknowledged him here. This is a splenic torsion that I got from Andreas a while ago. And they're not that common, but when you see them, they have a very classical distribution, imaging feature, which show what you would expect. One is they can have this kind of swirl sign of the vessels being toiled around each other, abnormal position of the spleen, like there shouldn't be a spleen here. And also you look at that the capsule is still rich, relatively richly supplied, but the parenchyma not so much. So, then the issue with splenic torsion is that the arteries are relatively rigid, so blood supply keeps going into the spleen, but the veins are more thin-walled and they collapse, so that's why you get the congestion. It's something to remember that all organ torsions are not the same. So in liver torsions and splenic torsions, you have normal arteries and veins, so the arteries are stiff. Whereas in pulmonary torsions, the arteries are not real arteries. So when the lung lobe torses, both the artery and the vein can equally collapse. There's no difference between the two. And therefore, you're not going to have the same issues of congestion, of blood being pumped in but not returning. So it's slightly different. Okay, thank you, Andreas. All right, we'll talk about pancreas.
Okay, we do have an adrenal gland.
Okay, let's talk about that.
From Jamie, saying, specific to measuring adrenal gland size on CT, can we use our standard normal range from ultrasound?
Oh, it's a great question. I think I would say that in today's time, day, and in today's age of imaging, we should all be very cautious with measurements because there's so many papers publishing specific measurements. There's so many demands from clinicians, oncologists in particular, to give us exact measurements. But then when you actually look at the methodology, how that was done, this is impossible really to apply this in a consistent and meaningful way. But once you put a number into a report, it becomes this eternal truth that cannot be debated anymore. which there's a number of problems with this. One is many people, on many displays, you get sub-millimeter measurement readouts, and they put this in their report. So they say width of the adrenal gland, 4.35 millimeter. Whereas this is obviously a false accuracy. This is not possible with a CT or ultrasound for that matter to measure in sub-millimeter accuracy. So it looks like you're pretending to measure something accurately, which you're not. And secondly, there's so many ways and angles you can apply that it's not really easily applied in a meaningful way. And even if we have larger structure like the heart on radiographs, well, then you get the other problem with the vertebral heart score is that you can confidently diagnose the obvious ones, but whenever it's borderline, these measurements are then not good enough to really make a cutoff to say it's one way or the other. So all measurements, I think, should be used with caution and also communicated with caution. And based on this, I would say, yes, we should use the ultrasound measurements that we use and add a layer of subjective assessment. Yeah, that, to me, it's something, I take the width of the adrenal gland, and between 7 and 10 millimeter is kind of normal to me. 10 millimeter big dog, 7 millimeter small dog. And then I look at the other adrenal gland and I make a judgment call on that one. I hope that answers the question. All right, we'll move on pancreas. So if there's comments on that comment, then you can interject again. First up.
That's all I've got. Thank you, Tobias.
Okay. We'll crack on with the pancreas. With the pancreas is kind of cool because it has a triple blood supply. This is from a paper that we published a while ago. So you got the gastroduodenal artery going towards the left. You got the craniomesenteric artery supplying from the caudal end, and then the splenic artery supplying the left part of the pancreas. And that has a couple of implications. Similarly, oops, wrong way, sorry. It also has a triple venous drainage, which is the gastroduodenal vein, then the caudal pancreatoduodenal vein, which drains into the craniomesenteric vein, and then the splenic vein that drains kind of, again, the left side. So that changes what happens to this organ compared to other organs, which usually only have one drainage route and one supply route. Okay. Another thing that's really cool is that when you image late the abdomen, by late I mean like 5 or 10 minutes late, you will see that the liver is often brighter than the pancreas. So this is the top bit is the liver, and the darker bit here, that is the pancreas. And that is because even with non-ionic modern contrast media, there is still a small fraction of contrast medium that doesn't get eliminated via the kidneys, which it should. If you think about the whole iohexol clearance, it states 100% renal clearance. This is how this test was designed, but it doesn't, because the liver will pick up some of that contrast and excrete it into the gallbladder. So then you can now see what is liver and what is pancreas here for the pancreatic body, which is sometimes really helpful because on pre-contrast, they kind of almost look the same. This is from an earlier paper where we also described the course of the common bile duct. So that was still done with single slice CT. So you can see that as well. And we'll talk a bit about diseases. So first about pancreatitis. So in acute pancreatitis, we got marked swelling. strong contrast enhancement, but there could be some areas that do not enhance because they're necrotic. And then we have peritoneal fluid and potentially saponification in the periphery of this, and that will manifest on CT as what we call fat stranding, strands of fluid in the fat. It's a bit of a poor term because it's actually not the fat that's stranding, it's the fluid that's stranding in the fat anyway. And there could be a little bit of regional lymphadenopathy. With chronic pancreatitis, we were not so good. You know, maybe the pancreas is normal, maybe it's a little bit enlarged. The pancreatic duct could be enlarged. That's something we commonly see in cats. And then the common bile ducts enlarged often as well. And maybe they are calcified. But we don't really have a good grip on pancreatitis and diagnosing that. Okay, so here's a dog, a Cocker Spaniel, with acute abdominal pain, and this dog had an acute pancreatitis, and you can see that affecting the left lobe. So all of this is probably the pancreas, and that's the peripancreatic edema and effusion there. And the left lobe, the right lobe is probably this, that was normal. So that's kind of what you would expect from radiography, kind of an ultrasound as well. So I'm sure you could deal with this when you see that's a likely diagnosis. Here is a Labrador retriever with pancreatitis on both sides. So the pancreas is basically chunkier, larger, and there is this peripancreatic edema surrounding it. So that will fit the narrative of this pancreatitis. You can see the portal lymph, the hepatic lymph node here. I'm not really sure that's enlarged, to be honest. So, but there's another lymph node, pancreatic one here as well somewhere, but not on this particular image. That you should check. Yes, so here's a collie dog with an acute pancreatitis. This we see here, the right lobe. So here a little bit of lobulated, and you see it all the way here, and also there's a bit of fat surrounding it that is patchy and irregular. So kind of a common thread. And here's a cat with a confirmed chronic pancreatitis. And I'm sure you have seen this in cats as well. So you see the pancreas here, and there's this large, it looks like a cystic structure, but as you follow it, you see it's ductal, you know, it's longitudinal. So these are the large pancreatic ducts. And then they often have an enlarged CBD duct, common bile duct as well. But are all cats that we see that have this enlarged bile duct, do they all have chronic pancreatitis? That is what I don't know. So, but I come back again also about that a bit later and then talk about this. Pancreatic abscesses and pseudocysts. So both are relatively rare. And usually there's the abscess associated with severe pancreatitis or possibly some sort of migrating foreign body. And the characteristic feature is that the wall is thick-walled, contrast enhancing. And with pseudo condition, that's something we see in cats. I don't remember having seen that in a dog. And the pathology assumed is that the pancreatic ducts are occluded, which, you know, as you know, cats have less options of drainage. They only have, 80% of cats only have a main pancreatic duct. And that then leads to a fibrous capsule that collects the pancreatic juice. And those ones have a more thin rim enhancement. And often these cases have also an enlarged common bile duct, so kind of like previously. So they also have an inflamed pancreas and cholangiohepatitis as well. But the rim is similar, is thin, and so it's not exactly the same as the abscess. That's not, abscess obviously filled with pus, and where pseudocyst is just that pancreatic juice. So both exist and have been reported. So here's a dog with acute necrotizing pancreatitis and a sclerosing peritonitis and abscessation. So, you know, somewhere in here is the pancreas. We got these large cystic structures. We got another cystic structure here, which almost looks like the caudate lobe of the liver. And then there's pancreas here. So, but the pathology seems to be particularly bad around the pancreas, and that's what it was at the end. So, and interestingly, these cystic structures don't really have a thick rim. That looks rather thin rimmed, but that was an abscess. So maybe it's not as reliable. There we go. All right. Here's a 12-year-old Bengal cat with an abdominal mass palpated, and that was diagnosed then as a pancreatic pseudocyst. So here is the distended common bile duct. I'm sure you've all seen this in cats. Another differential is that this is a cyst adenoma. One would have to see the gallbladder and everything here. And then a little bit further caudal, you can see this large cystic structure, and that little rim here, that is the remaining bit of the pancreas. But here the rim doesn't really contrast and hence much. So, you know, and there's no peritoneal effusion or fat stranding present. So that would put you more towards pancreatic pseudocyst. Probably want to keep both in your differential. All right, I'll let Maria finish. Okay. Okay. And next one is pancreatic edema.
I'm just going to interrupt. We have a question, and I need to just let you know that there's 10 minutes left.
Okay.
So Mauricio says, have you ever seen masses arising from the common bile duct?
I have seen, I don't remember, maybe, I don't, yes. And then we weren't sure whether they were polyps or whether they were a non-calcified list, because they could be colorless, which aren't necessarily mineralized, or whether they were masses. I do vaguely remember this, yeah. In dogs, as far as I remember. Another one? No, okay, cool. Let's crack on with...
Lily mentions that we had one that went to surgery with histopath 2 months ago with biliary carcinoma. It was a cat. It was causing severe biliary obstruction, and it was soft tissue attenuating. Thank you, Lily.
Thank you. Yeah, so this can happen as well. Let's talk about pancreatic edema. The important thing about this incidental finding, please, not incident finding. It's incidental, and it's usually a consequence of surrounding fluid accumulation. And on ultrasound, you see this tiger stripe sign, lobulated appearance, and you see the same thing in CT. And so here's an example of a dog with a pancreatic edema that has an ascites. So here's all the fluid, and if the pancreas swims in fluid, it will become lobulated and have these little stripes in it. Here on the other image, that's the tiger stripe sign. So this dog doesn't have a pancreatitis. That's very important. I don't know, can you always tell exactly that that's not a pancreatitis? Maybe not. But what you should be having as a very strong differential, that this is an incidental consequence of peritoneal effusion. And interestingly, the prostate does exactly the same thing. So if you have a massive effusion, if you have a male intact dog and the prostate looks the same, then they're very likely both just edematous. They're not used to swim in fluid. When they do, that's what they do. And it's not a disease. They're just adapting the best they can. Leave it alone. Okay, there you go. Exocrine pancreatic insufficiency, in which case the pancreas will be atrophied or partially atrophied. Can be inherited, or it can be secondary to infection or injury. usually in young adult dogs, and I always thought it's only in German Shepherd, but I recently looked that up. There's a couple of other breeds that like to get this. They have chronic diarrhea, fatty feces, vomiting, and weight loss, and you can do a CTLI assay to confirm that. But they, because of the vague history, there's lots of dogs with diarrhea and vomiting. They don't have that done in the beginning, and that's kind of how they look like. So this is a 5-year-old Pomeranian with seizures and poor body condition. So we did a CT for a portosystemic shunt, which it didn't have, but instead the pancreas that is here is tiny. This is a pancreatic body, and here's the right lobe. So bingo. It's a very easy diagnosis, but you're gonna have to be aware of it and look for this. And the clinical signs could have been a shunt as well. So keep that in mind. Okay, all right, next one. All right, feline diabetes mellitus. I don't have a case myself, but I just recently read this paper from Scott Seacrest, and it's very interesting, cool paper. So they compared diabetes mellitus cases in cats with non-diabetes cases, and they're larger, the pancreas, and the contrast enhancement occurs earlier. Now, okay, at this point, I'm not really sure that this will make a huge shift in clinical diagnosis of diabetes mellitus in cats, but nevertheless, it opens up the whole area of the feline pancreas, which we are still struggling with. And Scott has published a couple of other papers on the subject as well, which I'll still have to get through, but this is really good stuff that we get into those more subtle endocrinopathies as well. And there are actually some changes that can be seen or measured. Okay, this one belongs still to the exocrine pancreas insufficiency. It's just a question. So when in that dog with this insufficiency, he had this massive myosteatosis. So look at the apaxial muscles. They're all fully with fat infiltrate. And even here, the thigh muscles as well. And that probably has something to do with the abnormal fat metabolism in these dogs, that they possibly deposit fat in areas where they shouldn't be. So I'm not saying use this at all time to diagnose exocrine pancreas insufficiency, but keep an eye out for those. Those kind of are cool. All right. Let's see what else we have. We should be, just 2 or 3 more minutes or something.
5 minutes, Tobias.
5, okay. I think pancreas is the last one.
Till the end, everyone. So feel free to type them in, and I'll just pop them up to Tobias at the end now.
Okay, we're going to speed a little bit through the pancreatic neoplasias. So we got the exocrine one and the endocrine one. All of them are relatively rare. They're not many. They're usually malignant. You can get hyperplasia in the pancreas as well, but most masses that you will see in the pancreas are malignant, and most of the malignant ones are really metastatic. So there are other things to see in these animals. So insulinoma, basically neoplasia of the endocrine pancreas, and the effect is that these animals are hypoglycemic, and again, metastatic commonly. And here we see the behavior of these insulinomas. So the thing is, you should do a dual contrast study, and the perfect insulinoma will have a strong contrast enhancement on the arterial phase and not so strong one on the venous phase. And you can see that a little bit, at least on the one here in the left. There's another one on the right as well, that is the case. Unfortunately, it's not always the case. So yeah, you see it on the one on the left, on the right as well, really nicely. So if you would only count the one that have the perfect arterial enhancement, then you're going to miss some of them. Here's another one with a single insulinoma, and that one on arterial phase didn't show very much. Oops, sorry, I thought there was a mass, sorry. And on venous phase, you see this massive contrast enhancement. So they don't all contrast enhance in arteriophase. That's a take-home message. I think on this one, Staphyboardia, you can see that's the last caudal end of the pancreas. And now bear with me on this one. And there is the right colic lymph node, the red arrow, which is too big. That's not normal. And now, having seen that in a dog that's supposed to be have an insulinoma and doesn't have anything anywhere else, and this is very caudal again, and think about the triple venous drainage. So this tumor in the if it's in the pancreas, it should really be caudal somewhere there. So then when you look at the venous face, oh, sorry, that was premature. I thought there would be an error coming. There's just a little bit of contrast enhancement. That's all there was. So it was metastatic to that lymph node. So they can be really, really subtle as well. So, but that's not bad enough. Okay, well, this one here has venous face insulinomas. Yep. Okay. You can see here the masses that contrast enhance. I don't only have the venous face here, but they contrast enhance there. So again, arteriophase is not reliable as an only criterion to identify these. And it also had some splenic myelolipomas, which were incidental. Here we have one in the venous face that didn't do much contrast enhancement, but it did cause metastatic disease in the lymph nodes, hepatic lymph nodes, both of them being big, and also in the liver with metastasis. So here are the lymph node enlargements, both of them. I think the mass of the pancreas is actually this. I see more of them in the left lobe and the right lobe, but that might just be me seeing this. Another thing, this is where I started to say that's not bad enough, is that if you have persistent hypoglycemia, there's a whole range of other things that can cause this. And those are insulin analog producing neoplasias are the most important one in this clinical scenario. So you need to check for the stomach, extra stromal tumors that are maybe not even in the stomach, hepatomas, and even hepatocellular carcinoma. And there's obviously another reasons why glucose utilization or gluconeogenesis may be disrupted. But so here is a case that a colleague of mine published, and this really shows this nice large gastric mass, which was a gastrointestinal stromal tumor causing hypoglycemia. So if you absolutely can't find anything in the pancreas, please remember that it could also be somewhere else. Okay.
Tobias, we're at the end of our time now. Are you about done?
I think so. I just quickly go through the exocrine ones. So you can see these look really like angry masses with lots of little metastases in the surrounding mesentery, dogs in this case. In a similar case here, look at all these little serosal spread and also metastasis in the lungs. And this is a spaniel with a carcinoma, which on this one, maybe it's a bit not, so you wouldn't be so sure about, is this a mass or an abscess? And here's a cat with an adrenal carcinoma, and that was it. Okay. And that brings me to the end of my talk. Unfortunately, we'll not have our meeting in Edinburgh this year, but we'll do it in 2 years. You can mark down the dates already. All right, happy to answer any questions.
Okay, we do have a few questions. So, okay, we'll just go back to the discussion about common bile duct tumours. So Michael said that they have had 2 cases of cats confirmed to have biliary carcinomas. Mm-hmm. Okay, and then Mark said, just to clarify, the tiger stripe sign can occur with any peritoneal effusion, not just portal hypertension?
Yes, I believe so, yes. I don't think that this tiger striping edema is caused by increased vascular pressure in pancreatic vessels. It's caused by the pancreas being submerged in fluid, wherever the reasons are, yes.
Okay. And then Jordan says, for adrenal masses, any tips on differentiating invasion of the caudal vena cava from displacement and compression of it by the adrenal mass?
No, I think what I would say is you should be careful in your differential diagnosis, not be too confident, because it's impossible to really rule out invasion, particularly when it's also partially compressed. I mean, you could try positional things. That's easier to do in ultrasound, obviously, by rolling the dog in a lateral recumbency that the cava is up. You could try that and see what difference that makes, but I wouldn't hang my hopes too high for this.
Okay, and then Jane says, when performing CT for trauma, are you typically using sedation or general anesthesia and
Sedation.
any contrast?
We do sedation and we do the whole normal contrast procedure if we need to. I would say in many trauma patients, we feel we don't need contrast, like pneumothorax and stuff like this. So we don't always do it, but we do lots of sedation, the majority of our CTs are sedation only, and they get the completely normal post-contrast procedure and they don't react.
Perfect. Do we have any more questions, anybody? Okay. So thank you, Tobias. That was another fantastic talk. I think we all really enjoyed that. I am posting the, whoops, it's getting lost in all the thank yous. Thank you everybody for coming. I have posted the academia email address into the chats, and I'll do that again in a minute because I think it's disappeared. The recordings are going to be available on our website, so stay tuned and we will update you. Sorry it has been a slow process, but it will be ready soon. For all of you that have emailed about that, we've kept your emails and we will reply with a link when it is set up. May is MRI month for the summit speakers, as Matt mentioned at the beginning. So we hope to see you all there. Registration will be the same process as it was for these last talks. And the registration links will be emailed out early next week. There were a few people coming in at the end of this talk. I'm uncertain if that's because everyone is just really busy, or if there was a bit of confusion about the time of the talk. The talks are at the same time each week, so please just double check your time zones. Give us an email if you're uncertain about when to come in. So if you have any questions, I'm just posting in this academia email address in the chat function now. So please do just send us an email if you have any questions. Okay, thanks everyone. It's great to see you, and stay safe, and hopefully we'll see you again next week.
Thanks everyone. Stay safe.
Thank you. Thank you everybody for coming. Well, you can see numbers are going down. Da, 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 da. Whoa.
Okay, just before you close it, Tobias, I'll just respond to Olivia.
I can stay here for a little bit.
Olivia, they're going to be up soon. They haven't been posted yet, so we'll let you know when they're up. No problem. Okay, I think that's everything, Tobias. Thank you. That
Okay,
was
cool.
wonderful.
How many were we on?
We had 139.
Oh, not bad, wasn't it?
Yeah, that's good. I hope everybody's enjoying them.
Okay. Well,
Okay.
thank you very much, both of you.
Yep, thank you guys.
And we'll catch up again soon.
It sounds good. You have a lovely evening.
You too. Bye.
Bye.